some of the work in progress concepts that we have for coding for food today. Next slide. Thank you for joining us. Everyone's muted upon entry, but we are a small group, so you're welcome to ask questions at any time. All calls are recorded and are available on the Confluence, and we do use the chat. So please actively participate in the discussion by using the chat and send all comments to everybody so that we can ensure everybody sees your comment. And I always say this, but if you send it to just me and it's supposed to be private, I'm going to read it out loud because I have a hard time distilling what is to everyone and what is to me when I'm working and facilitating this call. Next slide. This is our common antitrust practices slide. So Gravity project participants have the responsibility to comply fully with federal and state antitrust laws. This is not just the avoidance of antitrust violations, but also just making sure that we avoid any behavior that can be construed as an antitrust violation. Next slide. All right, so we're going to be going through our little welcome. Coding for food, we really are trying to focus on that always first. So coding for food subject matter experts, gather your people. We'll try to hit that early in every single call. Hi, Katie Etman. We're then going to go through some updates on program classification. One of the things that's kind of new is that the coding for food concepts, there really are 3 concepts. And so the complexity of making a master list seemed a little odd as we were prepping for this. So the content in process is represented on the slide. So if you want to reflect on the content and reflect in preparation for the next meeting, the slides contain what we have so far. So there will be a link on the Coding for Food page to this presentation. It also just honors the fact that there's a lot of sandbox work going on in the Coding for Foods work. All right, and then we'll close with community homework and next steps. Next slide. Next slide. We are, again, nothing new there. We presented on utility and security concepts. You have about a month to comment if you want to offer formal public comment on our utility and security IC10CM concepts. The technical work stream continues to meet regularly Wednesdays 1 to 2 Eastern Standard Time. Implementation, the next meeting is October 31st. And we had a change in topic. So the new topic is going to be a deep dive in understanding how you're in a path forward to understanding how a screening instrument or assessment instrument is assessed as in compliance to certain regulatory drivers that are in the ecosystem, including Health Equity Plus, and tool suggestions from CMS. If there was a top email question I get, it is, does my instrument align with NCQA? So in order to support that, we're going to do a deep dive on how you can assess your instrument as being aligned, and our general guidance on how to align with Gravity subject matter expert reviewed and accepted instruments. Next slide. All right, any questions? Again, that is not for a little bit. October is a long month. As the person who has to write that presentation, I'm grateful for that. Next slide. All right, so what is Gravity? We are a collaborative initiative with the goal to develop consensus-driven data standards to support the collection, use, and exchange of data to address the social determinants of health. Next slide. Very, very grateful for all of our members. We couldn't do this without you. We also have significant in-kind support from friends at AMA and Civitas. So thanks so much for everything you do. It makes the teamwork, makes the dream work here. Next slide. This is our 2024 roadmap. And here we are. And so we're never coming down the pipe towards, it's about 6 weeks until we have our consensus vote. Just want you to feel very clearly that if we need to extend that, we had a little bit of a late start with Coding for Food, we can do so. Just know that the goal is to get that submission in in by early January. So I think we're going to be doing pretty good based on where we are right now, but this is our time frame here. We're not presenting the 2025 roadmap today. I don't think, actually, next slide. Let's see, did I leave it in? Next slide. I did. My apologies. I meant to take it out, but I'm going to talk about it anyway. There's a lot of work going on in Gravity. When terminology specifically, when we look ahead to 2025, our domain, right? So that's not this meeting, but the other meeting. Our spring 2025 domains are domains that we actually had on the roadmap a couple years ago and then had to pause as we kind of, shifted our funding strategy and took a little bit of a quiet time. But we are going to be addressing like long-awaited topics in person-level discrimination, including racism, ethnic discrimination, homophobia, transphobia, etc. And ensuring we have terminology to represent that and interventions to represent that. And then this is in alignment with American Medical Association request for a SC10 CM code to represent experiences of racism that they submitted at the March SC10 Coordination and Maintenance Committee meeting. But we're expanding it to do in the Gravity way to look at many different concepts in discrimination. And then coupling with that, we are going to be addressing topics in chronic stress because as anyone who works in the health equity space understands, there's the instances of discrimination and then there's the cumulative burden of it over time. This relates, again, was always intentionally paired with person-level discrimination. So concepts in minority strain and weathering and toxic stress and ACEs, all of which contain questions of cumulative experiences of discrimination. So weathering also is sometimes not just about discrimination. So there is a weathering concept of chronic stress that talks about just the chronic stress of poverty. But we'll be trying to lean into all of that really because there are such extensive literature on how that chronic stress relates to health outcomes. And then for fall 2025, our again long planned work to move from household levels of household measurements of food insecurity and housing insecurity to community level concepts. And so we'll be addressing food access and neighborhood safety in fall 2025. This meeting will likely keep going because we have a lot to address and we can't do it all in one meeting. And so Coding for Food is planned to have another cycle. We'll be doing that in the spring 2025. And then we are working with our friends at CDC to do a comprehensive gap analysis of housing instability and homelessness, concepts across screening, diagnoses, goals, and interventions and programs. And then we are hypothesizing that we'll try to pair into that enhancements meeting work on building terminology to support documentation of protective factors. If I have a precious thing that I've been wanting to do for a very, very long time, it is this, because if anyone's seen our lexicon slide, we know that we are not the sum total of our risk. And so we've had a very risk-based focus since our inception, trying to build terminology to represent that. But it is our assets and gifts and protective factors, our culture and community, our faith, our family that keeps us from being the sum total of our risk. And it's a core part of social determinants of health. They are not just negative. And it's a core part of family-based care and trauma work. So we're hopefully working in that space. The radical idea that records don't have to be just problem-based. Like, what's my asset list? That's my goal. I want to have a problem list and an asset list, which is very core across social work and nursing concepts. We've always had these concepts. So that is 2025. And again, very excited to go forward with that work as we and grateful for the support and partnership of friends who are helping us do that. Next slide. And if anybody wants to do any research on protective factors in advance, the Administration of Children and Families, SAMHSA, it is like core to everything that ACF does in their work in supporting families. So the most significant literature we have regarding protective factors is both in the work of addressing, addiction and addressing supporting families and wellness. And there's a lot to learn there. We're going to start curating some of that shortly for you all. Here we are. We're in identifying concepts phase of our enhancements meeting. Again, looking ahead, we have like 4 meetings to go before the vote. And so just note that we're keeping our eye on the timeline. I feel pretty good about it based on where we are with our work groups for Coding for Food, actually. And you're going to see a first version of some of what we're hashing out today. Next slide. Any questions? We presented where we are 2024, what we're looking forward to 2025. And it's pretty exciting stuff. All right. Okay, next slide. Here we go. Okay, this is the core work. We're going to focus on Coding for Food over the next chunk of time. Again, I will always try to center this first, just because if you are gathering your people, you want to make sure they come at the right time. Next slide. So you will find at the Coding for Food link, again, you're not going to find a master in the normal way you might find it. You're going to find a hyperlink to the presentation because the slides are the best master we have. This is a work in progress, and all of anybody who's in one of our subject matter expert work groups on Coding for Food, it's literally just the sandbox on a slide. So we've been working in this space we call the sandbox, which is kind of a identification, brainstorming, collaborative space. So that is where the community would go and review concepts. And then we are the program classification master. Will be posted as well. We have a new cadence just because we have a lot of things happening in Gravity, and trying to get to the Friday 5 p.m. PST master list was complicated for everything. We're giving ourselves the grace of time, and so we are posting on Tuesdays now. So the master for some of the work that the hyperlinks to the presentation will be available as soon as the recording is on the Confluence.
There's also,
oh, that was that's just a voice, but the formal program classification master will be posted on Tuesday. Next slide. And again, I just want to note part of this is created by the amazing team that has to deal with my schedule because I'm still in clinic 50%. So everything gets tucked in. And that means that the latter half of the week is very, very dense because I'm in clinic on Mondays and Wednesdays. There's just way too much to accomplish in 2 days by the time I'm ready to do this work. So we just shifted things. Okay, on to Coding for Food. So the why, we talked about it years. We've been talking about this, the why. We have a lot of materials on the Confluence. What we are doing, we're going to be submitting HCPCS level 2 concepts for 3 different things: medically tailored meals, medically tailored groceries, and produce prescriptions. There are things on the Confluence for review. And we want to note that especially some of these concepts that we were talking about right now are not necessarily focused on food insecurity as a domain of reference. They can be prescribed for multiple reasons. Hypertension, heart failure, diabetes, like any clinical condition of concern. There's a lot of literature in the ecosystem, but they are found under the food insecurity area of work because they will all be concepts in our food insecurity value sets in time. Next slide. Again, this is who we are. So you saw me say hello to Katie. The great thing about this work is that it's really a coalition of coalitions. So it's bringing many, many years of work in the ecosystem into the Gravity space. And then we have our friends at Fullwell. We have our friends from Freedmen's Health aligned with Partnership to Align Social Care. So we're all merging together in this forum to do this work. And then there were, as we mentioned last meeting, there are these overarching advisory committees, right? So we have a lot of subject matter expertise on this project. And it really is it just goes to show how critical and how important this is thought to be in the ecosystem. And again, the goal is to submit for those 3 concepts to MIRIS. And so I should say in January, we are developing the concepts in December, but we'll submit by the January deadline. Next slide. Right. So this is the advisory committee. Again, you see lots of friends on here and lots of experts we've worked with in different places, and I'm grateful for them. They kind of crafted the path forward for this work along with Kristen and Katie. Next slide. And then these are our different work groups, right? These are the subject matter experts of reference, immense, right? So we have produce prescription, medically tailored meals, and medically tailored groceries. And this will be there are too many people to put, usually who put SME's faces, there's just too many to put your faces. So this is the list of the amazing, brilliant people that we get to talk to regarding this work. Next slide. All right, so I'm now going to go into the content. SMEs, feel free to pipe in at any time. Katie, feel free. Anybody? Oh yeah, hi. People are putting in where they're from. Oh, sorry. My apologies, Michelle. I will correct that. I'm so sorry. I think that was incorrect. That's Sarah De Silva typing late at night and then not editing herself. Or okay, maybe it's Katie. All right. So the ecosystem where we are right now, like what codes do we have to represent the diversity of how food as medicine is implemented across the ecosystem? It all comes down to these three codes, really, from a HCPC code perspective. We have S5170, S9470, and S9977. And so our job as we go forward is to consider that these concepts will remain, consider how what we need is different, and ensure that we have the capacity to represent what we need. Next slide. So I just wanted to note some general themes, right? So I sit in each of these different work groups. And so there's some themes across all of them that are on the next few slides. And then we're going to go through the specifics of kind of where we are and what we're hashing out and like really sit with each of the slides on the specific concepts of reference. So the predicting and determining the exact value of the service is not within the scope of a service HCPC concept. That has to be hashed out in like fee schedules, et cetera. It's also really highly dependent on region. We've had a lot of conversations about how much value, like monetarily, are represented in the current implementations of each of the three concepts across very diverse areas, including like the difference between like Pennsylvania and Alaska, right? What we're trying to do from an equity standpoint is think about like a national standard for the amount, right? Like how much we feel like this thing is, and that correlates to how HCPC codes are used, right? You get a brace, you get a nebulizer, you get a medicine, you get a chunk of thing, and then the cost of what you pay is variable, right? Even short, like I'm family medicine, so like half of my life is trying to figure out how to get a medication for somebody at the cheapest cost, depending on their insurance, and it's just madness, right? So just know that we're focusing on quantity, how much is going to be the standard rather than the cost. And then know that in some sense that how much quantity needs to kind of like meet how these things are, how the different operational versions of the services are represented across the country. I want to note that there's a lot of wonderful resources out there from the federal government to help us do this cost quantity crosswalk. We were talking extensively regarding guides such as the Thrifty Food Plan from the USDA yesterday. We have a lot of materials that we're using to try to think through this, because thinking how much and what is the unit of how much is complicated. There's a lot of conversation about what unit we use, right? And you'll see some of those units in consideration over the course of the next few slides. We also just want to note that we are, many of the people that we're working with in these work groups are experts in food as medicine initiatives, and understand that the duration of these initiatives matters, right? How many months they have a produce prescription. Oh, we're still back here. How many months you have a produce prescription, how long you have medically tailored meals, how long you have medically tailored groceries. We also know that plans and different programs put limits on things. Oh, thank you. Yeah, I meant to, thank you so much, Katie. So there's limits, sometimes plans put limits on duration, but the actual duration and specifying duration is outside the scope of our work, right? So we've decided very clearly that we're not going to say to be done for 6 months, right? And so even though we recommend that it should be done for 6 months, so those are some of the early conversations that are out of scope. We can do that in implementation guidance, but in representing the unit of the service and its reimbursement, that's outside of the scope for that. I think everything I've said here so far, Smeeze, is like, we're all good. Okay, next slide. One of the things that we are focusing on as well, the general theme, is how to consider the medical tailoring of the concepts that adds the value. And we talked briefly about this at the last meeting, and is heavily dependent on the labor of registered dietitians and nutritionists. And so we're also trying to figure out how much tailoring should be the standard. There's many different ways that, medical tailoring happens. Is it by diagnosis or is it of the person, right? And so for all of these conversations, and I realize I have an email in draft that didn't get sent. There's a lot of things going on in Gravity. We're going to be really leaning into our experts who are RDNs, registered dietitians, and nutritionists, to help us walk through this. Because they are very familiar with how their labor is currently compensated or not compensated within current payment policies. Because in all medical tailoring programs, their labor is happening, the RDN's involved somewhere. And we're lucky to have friends who are experts within the Academy of Nutrition and Dietetics, within our work groups and within the advisory committee to help us get this right. So a quick little huddle, just trying to figure out how to ensure that we're adequately representing the medical tailoring of the RDN, which means basically like assessing the individual, assessing all of their conditions, assessing their nutritional needs, crafting a plan accordingly, right? That is inherent in each of the medical tailoring concepts we have. And we need to figure out how to represent it, even as we understand that labor is usually separate from the service that you give in HCPCS, right? It can't be really separate, otherwise the quality goes out the window, and we don't have the kind of services that our experts have been providing people for a very, very long time that are linked to all of those amazing health outcomes. So we just have to figure out how to take a path forward, and the A&D is going to help us. I don't know if I think we have, I don't see Carly on the call. That's fine though. But just know this is what because we work from a social justice framework here at Gravity. So if we're, if you are critical to the solution, you have to be centered in the solution. And grateful that we have so many RDNs as part of our work. Next slide. Another thing that we're talking about is understanding how modifiers can be used across each of our new concepts to represent what is different, right? So we are creating in our concepts the standard, what it is, how much they should get, right? What is the quality boundary for it, if there is? But there are things that add extra cost that need to be represented in the instance, and there's also different variations that have the capacity to be represented in different modifiers. So back in the day, or current state actually, right now, we presented on those current HCPCS codes, right? They're just a couple when it comes to food. So right now, those modifiers are being used to define the service as you look across the country, right? So and the modifiers are used in varying ways. Once we have a new HCPCS code, those modifiers can be used to represent these different kinds of variability, right? And what we're hoping to do is actually create a consistency in our recommendations for modifiers so we can support the kind of analysis that is one of the goals of this work, right? Oh, sorry. I say concept in the generalist sense, Michelle. If you want to come off mic, and we were talking about modifying is a possible cost, is a possible additional cost that might need to be represented in a modifying the food to meet mechanical needs is a possible additional cost in the service that might need to be represented by a modifier. Whew. Does that make sense? I see a thumb. I'm sorry if I put it there confusing by saying concepts, but that was the goal. I think what you're saying is that not all important critical characteristics that need to be represented to identify need and determine solutions we single. Yes, so that's a very wrong clear statement. What we're saying is there's a constant that is the standard that will be the code. Variations in that are historically, classically, always represented by modifiers to that code, right? So in a HCPCS sense, right, we'll have the base core concept and then things that need to be modifiers to that. If we want to represent the final mile delivery element or possible the additional effort of meeting cultural modifications and the cost and labor of that, and we want to track it over time, we will use a modifier. Hypothetically. Okay. Go team. But it would be great. No, nothing to update. It was a thumbs up. I used the word, we're all good. Yeah. All good. Perhaps, yes. So we're gonna get into duration in a second. We'll see. Okay. There's concept-specific modifiers are happening as well. Good thing I have the chat like pulled up right in front of my face. Okay, next slide. All right, I think there's one other general. Okay, I put this slide just as a kindness to myself. This is the first time we're showing you what's in the sandbox. So much of it is to be determined. There's a lot of italics, right? So everything is in process. Things that are in italics are really in process. Even if we thought they were set 2 weeks ago or 4 weeks ago, now they're back up in the air, right? So as we go forward, it's most important to think about the types of information we're thinking through and the places we're going to find that information and support it, because that's where we are, right? I'm trying to bring you into the SME meetings over the next few slides. Next slide. All right. So this just happened yesterday, and there were some late breaking things, and so the italics are very italics. So one of the things that's happening, very pressing, and again, all of you are on the produce prescription SME work group. Feel free to come. If I didn't represent anything well enough, please let me know. There's this sandbox where we're doing all this work, and I just pulled it over, right? One of the things that we're working on right now is concepts of quantity, like how much is the base unit. So what you see here is likely, but not clearly defined, is that there is an initiating action that starts this. It's ordering from some provider, not a physician, not a nurse practitioner, maybe an RD-RN. We can say that's not the case, but in the concept of prescription, it's usually the case in how these things are operationalized over the ecosystem. There's some kind of arrangement. The components of the service are absolutely fresh produce. We know this, fruits and vegetables. Late breaking, why it's in italics in a chat in the sandbox conversation yesterday. We started talking about dried legumes. Like people really wanted to make sure that we had dried beans. And so I just didn't want to forget that. Whoever was in the work group meeting yesterday and said, don't forget dried beans, I put it here. I saw you. Okay, that's fine. Qualified provider. And yeah, and you'll see that goes, we've gone back and forth about that. So Michelle, please explain. But again, not all the SMEs are in all the meetings. So just noting, yeah.
Thank you very much. I want to just identify that there's an important provider in here that would be left out in many states. And that's the registered dietitian, who's often involved in nutrition care. So licensed provider actually by federal statute in California precludes a registered dietitian from actually engaging community health workers to extend their work. So I would recommend using qualified provider or qualified healthcare provider, which leaves a little bit open, leaves it open. I wish we had licensure across states, but we don't. So I just want to point out that if you
My
put
apologies.
in
Yeah.
there, yeah, you
What
leave.
we'll have to say is qualified provider as evidenced by, right?
Yeah,
Because
that's
we
fine.
will need to state who can, and that's a no-brainer. We can do that. And I think I actually might have like flubbed and put this in here because I did this really late. So it might be literally like a typo on
It's
my part.
okay. It's okay. Thank you. I just wanted to, you know what? People actually assume. So I just,
No, I think it's literally a typo. I actually don't. I think it was just a mistake on my part. But
It's
that is
okay.
something that I'll take over to the sandbox is where we document all these this one actually. I don't want to change the slides, Hamali. So this will just come forward in future versions. And yeah. And then Fresh was also challenged at the very end of. Oh yes, that's Brent. Yes, that's why the dried legumes got in there. But you're right, correct. You imagine it gets adjusted at the next because things like squash, right? Is this what we're talking about? There was a lot of conversation regarding what we mean by fresh. Is that we want to see again? This is you have one slide for every concept. Have at it. And this is the first time you're seeing it because the sandbox is messy, friends. The sandbox is messy. So this is a great synthesized view to be like, I don't know. Have at it, Brent.
Yeah, I don't mean to derail the conversation,
No,
but in
please,
case it
this
caught
is
anyone
your
else's attention,
conversation. Yeah.
at the very end of the meeting, we started discussing a little bit about the types of produce, and there are frozen fruits and vegetables that are often parts of these produce prescription programs, as long as they're not covered in sodium and sugar and extra additional add-ins and processing. So there is a nice definition for that I imagine we'll get to in the next meeting.
Fantastic. Okay, perfect. Okay, love it. And I had froze. It was in a comment on the side, I think, of the sandbox, which is why I lost it. All right. So, I think Katie Etman, can you help me track these things, my friend? I'm sure you can. Thanks, bud. Okay.
Sarah, I had a quick question about the order from a licensed provider. I mean, ideally, that's what we want, but sometimes we get self-referred. And I'm sorry if I missed conversation passed on this, but just wanting to know, are we able to bill if like if we enroll them, or we need to have the licensed provider has to make the referral no matter what?
No, that's why it's in italics. We haven't settled that one. That's one that we keep talking about, but you're right. That's like everything. The initiating action is completely, there was some conversation regarding protein, but that crosses heavily over with medical tailored groceries, which is why it's not in here. So sorry, Erin, I'm answering your question. To be determined on whether it has to originate from a licensed provider or not. Okay. And I'm fairly certain, Brent, I agree that we should end up with all. And then protein, no, because that's groceries, right? That's a different thing. And oh, and Brent, thank you. You're helping. Brent, you're helping with people too. Love it. Okay, and then okay, so
protein
Michelle,
would be for medically tailored grocery, correct? And medically tailored meals, not produce prescription. Okay.
Correct. Yeah. Absolutely. And then Michelle, I think your comment on why dried relates to what Brent was saying, is that there is just something we hadn't discussed, canned, frozen, etc. yet. And it's likely coming. So I think that answers your question. Brent's question does. And okay, that's all it's all the okay, this is all related to the reaction to the fresh, I think. Yeah, so Scott, one of the things that we just mentioned is we've talked about cultural tailoring really intentionally. And so with the two different ways we've talked about it, one as a facet of quality, right? And another, no, Michelle Kupich, it has not been determined that it needs to originate from a qualified provider yet. It's in italics. And then Scott, we've also talked extensively regarding a need to represent it as a modifier. That's why it's in there, all theme modifiers, because we know very clearly that number one, it's something we want to discreetly see when it's happening and be able to track. And number two, we understand that sometimes it adds additional, like the entity that's providing the service has to take different methods in order to meet the person where they are in their cultural needs. It also relates to the next concept on talking through concepts of choice, variety, and quality. I don't think I've gotten there yet. I was going to hold space for this for a second. Because I'm going to go back to that, because the talking through concepts of choice, variety, and quality will make more sense when I get through the table. Okay. Quantity. We have had a lot of conversation across every single one of our meetings regarding how much, right? I mean, 3 meetings, meaning produce prescription, medical tailored meals, and medical tailored groceries. And this is keeping me on my toes, friends. And so we had an idea of 16 servings per week for some time. That's kind of a late breaking thought, because someone at the end of the meeting, one of our subject matter experts, is like, are we set on 16? Why not 24? Why not 32? Which is why it's in italics right now. And we've had a lot of conversations regarding the language that clinical entities use and the language that different providers use, like food providers, like food banks versus farmers versus like all the ways how much a person is getting is manifested, right? And so we are working on a way, and we're, Dr. Chen was talking about this crosswalk to talk about servings, but also have like an asterisk equivalent to X blank pounds, cups, etc. per person, right? Totally in process. We were just talking about this yesterday and the meeting ended and we hadn't gotten there. Well, we do recognize we need to define some kind of consistent quantity, so there's some consistency. We want to make a unit of that quantity that is able to be replicated across multiple instances of the programs. And there is a lot of commentary on this. So luckily we have all of these experts in produce prescription who have all of these citations of things that they've mentioned before, and we'll land quantity eventually. Are you okay? So regarding Rob, I promise I'm coming back to choice, variety, and quality. I see all your concepts there. So quality insofar as meeting nutritional guidelines is something we talk about all the time. So that's something that can't be remiss, but I'm coming back to you. So far, the unit of reimbursement that we've talked about is monthly, because almost all of the operational versions of this are monthly. It might change, it might not be monthly, but for right now, it's either all the versions that we've been talking about are monthly. Variations, we need to consider these in our HCPCS code, and maybe we'll express them in a modifier. There was a desire to think about the 2 different HCPCS codes for these 2 different ways that the service is provided, either as a prepaid produce card or direct provision of produce. I don't know if we're going to get 2 concepts, and so it might need to be represented by a modifier, and that relates to the choice, variety, and quality conversation. Okay, Michelle, do you have a question? I saw your hand.
It's
No?
okay. I'm just trying to listen and not ask and not talk.
There's no reason to not talk. I'm only talking because I'm the default talker. It does
Yeah, I
not
think it's
mean
just- Yeah. No, I'm listening. I think I had an initial gut reaction to the monthly cost unit, and what you are saying makes sense. I'm also thinking about the importance of really just defining a baseline unit, for which you could have different units that would be dispensed, if you will, or prescribed based on an indication. So if somebody, I'm just going to use the most basic one that's easiest for me off the top of my head, is hypertension and the DASH diet. If there was this was used for, again, beyond food insecurity and for therapeutic purposes, I would say you need a minimum of that is 5 to 9 servings of vegetables, you know, per day. And so your prescription might look different. And so because in the recommendations will change over time, right? We might learn more about something. And so, yeah, I think it's.
This is where, yeah, this is 100%, Michelle, this is the start.
So the monthly thing, I'm thinking about it from a payer. Well, and so then I know we're getting like a little bit removed from the definition. We start thinking about how it is redeemed and how it is reimbursed. And what if someone, you know, just uses it for 2 weeks? So
That's why it's in, we did talk about that, like what happens in these iterances where you drop out of the program. Interestingly, one of the other work groups has a retroactive, like you bill for what you gave, but we're leaning into all of these concepts 100%.
Excellent.
And one of the problems about increasing the quantity in the base amount is that you can't stack them, right? You have to always have 32 for the month,
Right.
and you can't do 16, right? And so, but you can easily, for a person, if they're on the DASH diet, do 2 16s.
Exactly.
Right?
Exactly. That's what I was thinking.
Yeah, and that's the thing is we're again, this is common that you wait to, are you in the medical keto groceries one? Yeah.
No, I'm in groceries, but you know,
No, I'm just saying, because wait till we get to the meals, because that's an instance, right? And they are doing that for a very specific reason. So
Correct.
Michelle, one of the things we want to consider, if as we increase the quantity, we decrease flexibility, right? Because I can do as
Right.
many instances of a HCPCS code per person based on an indication as I need to, right? But I can't, but I'm not always going to aim to the top, right? But maybe because of the person's needs, I will, right? So Michelle, 100%. That's why it's 16 in caveats. I had not had time to say just what we just said in the produce prescription because it came literally at 12:55. When Brent and Katie Katie wasn't there. Brent can testify. He was there, and I was like, oh, and so I put it down, right? But
Yeah.
yes.
Although I'm scratching my head about there's 7 days in a week, and I'm going, how do we get 16? But that's for a later conversation.
I know. Yes, but I hear, because all of these thoughts are really helpful, and I think so far, produce prescriptions, besides the fresh thing, does this feel like what the conversation we've been having over the last, like, am I missing any salient points so far? We're good? Produce smees, I
I
see
don't
you.
think so. I would say maybe an expression of the difference in delivery mechanism. And I think that while we've touched on it as part of these other subjects, I don't think we've really wrestled with that yet. But
Yeah.
I do envision that we're going to have to spend a meeting focused on that, whether it's delivered to your doorstep, you're going to shop for the produce, and there are other
Exactly.
ways too.
Yeah, perfect.
But
And
it's come up, but it hasn't been the sole focus of any conversation.
I know. Let's put a little pin in that. Coming back to you next meeting. Denise, and then Adam, and then I want to do I do want to unpack the choice, variety, and quality, and so I can get back to Rob's question over here. I have Rob's question held right here. Denise.
Oh, hold it. I'm following along. Just want to say, have you considered or will consider dealing with the homeless is my my passion here. We usually have been using the Thrifty Food Plan and backing into the amount of money, which you alluded to when we started, and then deciding if it was one time or monthly. Just saying that was the easiest mode of disbursement that we had. Just wanted to put that there.
Thank you,
Because
Denise.
it's all going to depend on money. And then especially when we go into fresh, canned, which the homeless, it was like, are they going to the farmer's market? Are they going to the food bank? Are you coming back? So we just did the prescriptions based on one time and monthly. And I'm trying to put my hand down.
Yes. So one of the things we were talking about yesterday was the capacity of the Thrifty Food Plan to do that crosswalk between quantity and cost, right? And all the ways you can do the little like regional adaptations of it. So Denise, that's like right on the money. Like we're thinking about cost even as we talk about quantity. Adam?
Yeah, hi. So Adam Shivich from About Fresh. You know, I think there was a couple of comments made about using produce prescription as a food insecurity intervention. And I think one of the conversations we're having in this group is the wisdom of applying produce prescription so broadly, as opposed to focusing it exclusively as a therapeutic treatment for diet-related illness. And there are a lot of political forces at play that are, at least to my mind, would make it much wiser for us to focus on produce prescription purely as a therapeutic intervention for people with diet-related illness and a level of food insecurity. But that's a very important conversation for us to continue. I just wanted to highlight that as another point of conversation within this team.
Thank you, Adam. And I tried to lean into that when we're talking about where the work is on that slide, even though it's not all food insecurity, it's in there, but thank you for bringing that back. All right, so now I'm going to throw the choice, variety, and quality bomb. We spent a fair bit of our time yesterday talking about how the different versions of how these programs are operationalized around the country relate to quality of product and consistency of understanding what the person is getting. And so we sit in that at this time, right? And the complexity of understanding that in some instances, you have money and you can spend it on produce at the store at your own choice, right? In some instances, you are getting a curated box of produce and you do not have that choice. In some instances, the box might not be totally curated, right? And so there's various representations about how this is happening across the ecosystem. And in some, we even have an instance visiting a food bank version. And so we are very much sitting in the complexity of that conversation and trying to craft a standard regarding that, and talking about benefits and risks of all the different ways and trying to create a standard going forward. We're not, I would say we haven't settled this one, but we definitely, so we do, we have as defined by WIC and SNAP in our medically tailored groceries version, I believe. But just know that this is where we are, definitely trying to figure out how we represent quality, how we understand variety, especially as it's related to dietary recommendations, because variety is important, but how we support choice and autonomy as we do all of these things. That's a very philosophical statement, trying to cover the complexity of everything we addressed yesterday. And I think that's probably touching on it. Okay, so we have some edits. Like one significant edit is that I shouldn't have put license there, and I think that was an error. And then the fact that the components, I didn't represent some of the complexity of what we arrived at yesterday and will likely nail down. There's things that you will see there that aren't there now, because the addition of non-fresh produce, including canned and frozen. Anything else? So there is work, we do imagine creating a correlating CPT code in time. There's no reason to not. The specifications are very, very similar, and we have friends at the AMA to work with on that matter. Our original work was focusing on HCPCS just because of the extensiveness of these concepts in Medicaid waivers and in lieu of services, but deeply understand that there's other uses for them as well. Correct. I know. So Denise, you're right there. So as we create the standard, we're definitely talking about the middle ground between all of the different versions. Rob, before we go on to medically tailored groceries, a thought, friend?
Yeah, I'm just trying to catch up, I guess. So when I look at the sort of things that you're talking about, I immediately start thinking about a model and not a code.
Oh.
And I'm wondering, are you thinking of a code and not a model? I mean, are you trying to come up with a way of representing all of the stuff that you've got in that table with a HCPCS code and modifiers because you have to?
That is what commonly HCPC codes do, right? We're actually applying various models and creating a synthesis of them to create a code.
Well, no, you're right. HCPC codes have modifiers. I get that. And so it's a way of, it's just, there's those of us that live in this world think of this as the terminology modeling conundrum. What goes in the model versus what we make a code for to put in the model. And if, these things sometimes are just dictated to us. So you got one slot, you put a lot of complexity into the terminology, i.e. something like this with a lot of modifiers. Or you start sending a more complex object and say, this is what I want to communicate. And I'm a little unclear on whether we're trying to model the order, a diet. That's a diet order, is what that is. And so are we trying to model a diet order, which in HL7 parlance would be a more complex object than just a code? Or are we just trying to kind of fill the tiny little box that we've been squished into, which is we can only send a HCPC code to do this work. And therefore we have to put all the complexity that we want to try and communicate into a HCPC code with a lot of modifiers. So is it that we're in that little box and we must do the latter? Is that what I'm hearing?
We absolutely require HCPC codes to represent the standard at the current state of social care.
No, I get that. I don't
Yeah.
have, but can we, is this exchange? Because these are always exchanges, right? You got somebody, in this case, a qualified provider who's trying to communicate to somebody else. These are the things this person needs or should go get. Right?
Okay. Oh, I'm gonna actually flip it. That's actually not what's happening. This is the community-based organization communicating to the payer that they did the thing. This is not the order for the thing.
Okay.
This HCPC code will represent, my apologies, I realize I might not have been clear on that. This HCPC code represents what's on the claim to
Okay.
get reimbursed for the thing.
Okay. That I get that. And so I think that's an answer to my question.
Yeah.
Granted, orders and claims are different things, but in the context of this general model idea, the idea of, can I send something complex to you? Like, I'm seeking reimbursement, and the information that I'm sending you is, in today's parlance, if we live in the future, be a fire object, right? That has all this information, like what was actually delivered, how long it was done, how many of it was done, whether it was done via prepaid, all of that separate pieces in separate slots and an object like a fire instance of a profile.
Yes.
But no, here we're saying, look, we can only send a HCPC code. And therefore, right now, we don't have HCPC codes that are complex enough to put what we want to say to differentiate different cost reimbursement schemes. Therefore, we have to create, okay, so there's a lot of head shaking. All right.
Yeah. And then know that some of these,
Unfortunate.
yeah, true. And note that some of these things are really because they're interrelated. Like we need the monthly component to understand quantity. The monthly component probably won't be a highlight in the HCPC code, right? But they're interrelated and you'll see this as we go forward.
I like the fact that you're taking complexity out of the code. So, okay. Anyway,
no, I know. We're trying.
Now I understand the game, and
Great.
I'll stop asking you to do a different game.
We are helpful, Rob. Thank you. All right, my gosh, Brent, thank you for dealing the yes, okay. So it is true in many instances we can't double enroll somebody. Brent, thank you for adding that in. It's been a long week, so my apologies if words are not coming clearly. Let's move in. I mean, here we are. It is 4:57. We have 2 more concepts to cover, so I'm going to keep moving on. I think the truth is this conversation and what we've had, you'll see themes of that carried through, right? Because there's a lot of consistency in and how we're trying to represent things, but there's just some differences. Next slide. Okay, on to medical tailored groceries. So remember, medical tailors in quotes because remember, it relates, the moment you're tailoring something, it's relates to some degree of an RDN assessment of the person, right? So it's in quotes because we understand that in order to represent this service and how it's operationalized in the ecosystem, it requires an RDN to be involved. The moment you're using RDN, it requires an RDN. The moment you're using medically tailored, it requires an RDN. Michelle?
Yeah, I mean, I think the medically tailored, to jump in, I think that it is beyond that. It's really that the groceries adhere to standards that are informed by guidelines. And how do you get there? That's the intellectual property or contribution. And so it's not that it's an RDN that is the only, it's the standards. And I think that's what's missing from the description.
Oh, see, but what we had thought was that there's two different concepts we were working on. One is planned for the spring. Originally, medically supportive groceries was thought different than medically tailored grocery because they're operationalized differently across different implementations. Right. So this concept was supposed to represent when the RDN was involved, right? When there was like a diet plan for a specific condition.
Yeah. So I'm just gonna hold. I think
Is that true? No.
I think it's two things. I think that if we are talking about the groceries themselves, it is about what is there, that the components are actually, all of that food is intentional, and meaning that there's been a look at estimation of what the population with the condition or conditions needs, and that is translated into groceries. And then there is that, I'm just going to say, screening or an assessment that is a different piece. So I think there's two components that get conflated that are, so,
Yeah.
you know, and I know we don't have time to do that today, and I'm not in the medically tailored groceries group, but I think what we are doing in medically tailored meals, there are some similar things. So I'll just save my comments for our next work group meeting.
But that's one of the things we're talking about, Michelle, in the medically tailored groceries meeting is if we have to consider the medical tailoring part separately, are there actually two HCPCS codes? Right?
Yes.
Because is it just the groceries are the groceries and
Yes.
the tailoring is the tailoring? So
And I
that's
think,
not,
right.
yeah.
And the word tailoring is kind of made up, and I think it's about what is occurring. And what is occurring is an assessment, and there's already coding for that. But the fact that you have to tie these together, that you're correct, and that for it to be medically tailored meals, there is a professional component.
And this is the sticky wicket medically tailored slide, right? Because, okay, yes, thank you, Michelle, for your brilliance. And this is why we all come together, because all of you are subject matter experts in everything, and dividing you off into little work groups sometimes is not great. So yes, I'm just going to quickly go into the components. So one of the things that's happening, so these two meetings happen back to back on 2 different days, one at 12 to 1 and one at 12 to 1 and one at 11 to 12. And there's incredibly similar themes happening across both of them, because both of them, again, medically tailored groceries and medically tailored meals have these core components. Right. And again, my apologies for licensed across all these. I copied the table, I messed it up. It's an error, and it's in italics because it hasn't been determined yet. But we talk about this, right? Like where it originates. That's one of the components we have to figure out. The components of the service, you can see some of these. This is one of the things we have in our sandbox is aligned with nutritional benchmarks for federal approved programs such as SNAP and WIC. The quality component, just like just like what we're saying in the chat there that Brent and everyone's been going back and forth, this came up as a grounding theme in our medically tailored groceries work, right? Like how do you create boundaries on what kinds of foods we want in the grocery package? That's also a common theme in the literature scan regarding how all these things are operationalized across different states. That's a very common, like what it is. And so one of the things we are stating, and this relates to, I think it was Aaron was talking about protein. Where does this fit in? This is where it would fit in. We're very clear that we wanted to allow for perishables if you're able to have perishables, because some of the, think of all the things that come to you from one of the meal kits, like all the capacity to represent that in a grocery package. Quantity is tricky. And so there's lots of these units you see here in italics are some of the units that we're trying to hash out. Like what is, like how are we just defining how much? And the reason why it's up to 2/3 is because that's when we don't, that's the over the 2/3 line is where you start to breach certain Medicaid policy. And so we're trying to be thoughtful about the fact that we're not going to shoot ourselves in the foot and go over it, right? Michelle, what you were saying before makes sense here. If you keep a lower unit, you can do multiples for different instances, right? And our unit of reimbursement still is monthly here. Yes, yes. You think the nutritional benchmarks would be, oh, okay. Okay, got it. Okay. And then service variations, we do note very similarly to produce prescription. Sometimes you're getting a prepaid. Oh, sorry, I said produce card. I forgot. I didn't. Grocery card. Errors. Sarah's making errors on a Thursday afternoon. And then sometimes you are offering a direct provision of groceries in a grocery pickup. Again, the unit of reimbursement, we're still thinking about it. The components of the service, we're definitely still thinking about, and the quantity is we're definitely working through all of that. Would there be someone who's a SME, so would there be differences in quantity? That's where the DRIs come into effect between. I'm not going to say. I think people have different amounts. I'm going to say can have different amounts depending on the needs of that person and the size of that person, right? According to when you think about DRIs and servings. Not everything's based on the 180-pound man, is what someone said, I think, in the meeting. And age, exactly, like a child, right? Exactly. Okay. Okay. What I will do, because now I'm just embarrassed that I'm gonna, before we do the link in the master section on the coding for food bit, I'm gonna fix some of the errors on the slides. Oh, hi. Look, I'm sorry, I sent a direct message. Our friend from the A&D just popped and said, hello. Hello, Carly. When we speak about centering RDNs and solutions that involve RDN labor and lean heavily on RDNs, and I mentioned that we had friends at the A&D, that's a lot of acronyms. Registered Dietitian Nutritionist, American Academy of Nutrition and Dietetics is the A&D. Carly is a friend from A&D. Hello, Carly.
Sorry, I had multiple meetings all at the same time, so I'm trying to pop in.
No, it's great. We have all kinds of food for thought regarding one of the things that Michelle was mentioning with the difference between the tailoring and the service, right? And how like the grocery is the grocery. And Michelle, I think you are part of the Medica Tailored Meals meeting with Carly, right? Right?
Yes, Michelle's on that one with me.
Okay.
With us.
Okay. All right. So we have a lot of food for thought to bring back to those meetings. And I haven't sent the email, but I said I would send, Carly. So I will very shortly to gather RDNs on solutions here. Because one of the problems, and just noting, and I mentioned this on the slide, is even if the RDN labor and assessment might be separate, RDN labor and assessment is not well compensated for nationally. And so uncoupling it has significant risks to the critical labor and expertise that is driving the outcome, right? So it's a tricky stew that we are committed to trying to figure out. And luckily we have friends who are helping us. What is it? The medical nutrition therapy is only reimbursed Medicare. What is the horrible policy there?
So it is in statute that medical nutrition therapy is reimbursable for diabetes, chronic kidney disease, pretty much just stages 3 and 4, and then 36 months post-transplant. There is some access to dietitians through IBT for obesity, but again, that is a different service. But the Medicare benefit in and of itself is pretty limiting. It is also, however, though, underutilized. So even increasing access and increasing utilization among those limited populations would tremendously increase usage. There is also the Medical Nutrition Therapy Act currently active in Congress. It's bipartisan, bicameral, looking to expand the number of diagnoses that CMS can have on their register in order to provide medical nutrition therapy.
Thank you, Carly. Wonderful. And Michelle's noting that several states have added MNT benefits in Medicaid programs, but coverage varies. So suffice to say, you can see why we're trying to lean into this, because we need to. All right. Okay. So now on to medically tailored meal. Is any other comments on medically tailored groceries? Again, there's similar themes here on what we're doing in other groups. And then Calvin, it's a great question. Again, because of the tailoring, again, it would be food insecurity plus usually. But any way to increase the capacity for RDNs to do the assessment that drives the tailoring that creates the outcomes for individuals is really an important step forward. All right, next slide. Okay. I did that again, error, licensed, my apologies, qualified. I'm going to strip this up every single time we go forward. This is a tricky one. There's been a lot to represent. There's a lot of conversation about this. One of the things I want to note that's different is the unit of reimbursement is pretty consistently thought to be like a meal/serving. And I said serving to represent the complexity of what we're talking about, how meals get provided. And I have this asterisk here because I tried to represent everything we had in the sandbox. Although we might think of 3 meals a day, that is not necessarily how these meals are provided, right? It depends on the assessment and the person's needs. Like some people, because of their conditions or because their elderly status or because of their personal diet preferences, need 8 small meals a day, not 3 large ones, right? So we're trying to represent how that happens to meet the person, but still represent a common standard. I put snacks there just because we keep on using meals, but we haven't figured out the components of the service bit yet. We're still using meals, but we're not just talking about meals in the classic way. So I put that there. And we have very clearly specified in this instance, it is bound to disease-specific modifications. That's been said consistently, and it's been part of the what for some time. Everything in quantity is to be determined, right? Hot topic, right? Is it a percent of the person's daily needs up to, and we've had our up to 2/3. Exactly, right? So agree that 2/3 is the desired intervention. And so if you have 1/3, you can do 2 1/3. Right, Michelle, this is like what you and I were saying before. If we create a low unit, like a simple common unit, you can multiply it. And then what it's evidenced by, these are all things in flux, right? kcal equivalents. Oh, sorry, I have a call coming in, decline. Nutritional components. I did not spell out nutritional components because when we spelled out, it got tricky really quick because depending, if you think about like the My Plate and your protein and your starch and your veg, it doesn't meet disease-specific modifications super quick. Like if your disease means that you're not supposed to have starch and you have your My Plate version. And so that's there. And then we're also talking about, because RDNs are very involved in this usually. We've also talked about percent of total needs, including macro and micronutrients. Thank you, Michelle. And again, not inclusive of all the brilliance of the sandbox, but so note that the order is to be determined and the license needs to change. I got that. The components are inherently a meal, but we're trying to think about what a meal is because it's definitely not just 3 meals a day. The quantity, we're thinking about it in like some degree of a unit that is related to the nutritional needs of that person as assessed. And then how we reimburse in this instance, what will the HCPCS code represent? We're very clear that it's going to be like that percent of the person's needs for that day. So for a day, if you're getting the equivalent of 2 meals, for that day, it would be 2 HCPCS codes. Bam, bam. Or like, or the HCPCS code and a modifier with the quantity, which is what we really do in real life, right? In like, all right. Have I represented? Correct, Denise, this is the whole thing. It's like, so we have to, the reason why there's variability here is that we really want to be able to meet people where they are and their nutritional needs and their preferences and their conditions. Not we want to, we have to, because that's what medically tailored meals are. And still create a standard that's able to be referenced. Great. Any other thoughts? Brilliant people? Medically tailored meals, SMEs? This is our first like real coding for food consensus meeting. We're doing a really great job. I'm really glad it's recorded because I'm gonna have to go back and listen to it to make sure I apply all the wisdom to the sandbox. I also am gonna beg my SMEs to please carry all of the little things that you heard into our next meeting and be accountable to them because I want to make sure that we do them justice. Michelle? Yeah, I saw your hand up.
No, I'm gonna hold until next week, but I just have never mind. I'm gonna hold till next week. Thanks.
I love your smart brain though. Come on, bring it.
No.
Okay, we are meeting next week. Okay.
I think this is just a general question. Again, I apologize. I wasn't able to meet at our meeting last week, so this may have been addressed, but it is, based on my experience with coding, it may or may not be connected to the ordering provider. So the question is like, is that an absolute?
No,
I didn't think so. Okay, I just wanted to confirm. Thank you.
no, absolutely not. Heavily italicized, and it's just something that hasn't been resolved yeah, absolutely
I
not.
mean, and I guess the story that I would share for us to think about is, I'm just going to use the example of medical nutrition therapy. Carly was just saying that there are several statutory issues. One of them is that this is not statutory, but it is only a physician or a DO that can refer for medical nutrition therapy in Medicare. And the MNT Act, we have been fighting for a very long time to change that. It was the only way to get the AMA to support the first MNT benefit that became effective, I think, 2002, correct me if I'm wrong, but NPs and PAs cannot even order for medical nutrition therapy. So I just want to caution the requirement for an ordering healthcare provider, although we are connected to it, if that makes sense. I think we should really think through that.
I think that makes a lot of sense. It's like MNT and diabetic shoes.
Thank you.
Hi, my name is Sarah DeSilvia. I've been practicing family medicine for a very long time, and I cannot prescribe your diabetic shoes. I am so sorry.
I will say though that we, in the MNT Act, we have asked to have that removed. So the act going forward does not, it opens the referral requirement to PAs and NPs. And that also isn't necessarily the case in private sector. I know we're dealing more with, in the public realm, but it is definitely a limitation within the Medicare space.
The great thing about Gravity meetings is all of you get emboldened to go out and fight for things you didn't know you had to fight for before. Now you have it in your list of like equity-minded things. You're going to go out there and fight for people having access to food. Go get them, tigers. All right, any other questions and comments on this slide before we do? I want to wrap up there's just some highlights from program classification. We've had a really wonderful conversation on coding for food. I'm glad we have its own meeting. Katie, can you imagine trying to do this in a meeting with 2 other domains? My word. Any other thoughts and questions? Again, we'll meet. We just met with produce. We're meeting again. Brent's taking notes. Thank you, Brent. We meet next week with medically tailored groceries and medically tailored meals. Incredibly grateful for all of your insights. Sorry for my slide errors. Okay, next slide. I'm going to fix the errors before we hyperlink to the master. So at least the errors are not correct. And then, Brent, is the fresh vegetables, is that the other versions of the vegetables, did we talk about it enough that I should fix that? I don't know. I didn't know. Yeah,
It
I don't
was at the very end, and
you
it was
didn't
just thrown
land
in
it.
there
Okay,
last
I just want to
minute.
make sure. Any error I want to lean into, and I definitely the license was an error because I did not, that was not said. Okay, sounds good. All right, so next slide. We're gonna go on and try to do a little, okay, now we're switching to a totally different concept. Welcome to the enhancements meeting. Next slide. We're gonna go through quickly just some updates in the program classification master you all will see on Tuesday. Thank you, subject matter experts for Coding for Food, for coming to this meeting. Thank you, Katie, for your leadership. Thank you, Brent, for being part of the advisory committee. Wonderful. You all are I'm so grateful for all of our experts, for RDN wizards, and I will see you all next week. Some of you. Okay, now moving in to program classification. We don't have a ton of time, so I'm going to try to go straight to the slides that are of reference. Next, I'm going to go straight to the new content. Next slide. Next slide. You know what? We talked about it a whole bunch. So next slide. Next slide. Thank you, Molly. Next slide. Next slide. Okay, this is not even remotely new. We've talked about it every time. Next slide. And this is also not new. And you're going to see this, though. I'm going to level here for a second. You're seeing us. We have our high-level groupers. We have our high-level concepts, our program groupers, gravity concepts, and then we have further levels of granularity that are represented in social care taxonomy, such as 211. Okay, I don't think. Okay, I'm not. None of the chats relating to me. I'm just making sure. Next slide. All right, so we have our primary need, food. We were just talking about food. A primary need is food. We have the facet of the primary need. What about food do we need help with? These groupers that we're creating to tag for the purposes of navigation to and connection to services. And then gravity comes in with a further degree of granularity, and then incredibly grateful to all of our friends from 211, very involved in this work, that have even further granularity than gravity goes to. Gravity really defines things that are constant across a national standard, as you are aware. So the further specifications are something that we don't drill down to. Next slide. So we had, last time when we were here 2 weeks ago, we talked about housing, because when we started to do the analysis of how our classification worked for housing, we just didn't feel like it was working as well as we wanted to. Housing is super, super complex. So this area went under significant review and revision. We had a fair number of huddles just trying to think about how we wanted to group things. And we were presenting here the past classification structure and the new classification structure. I will also go into a domain we haven't addressed yet, which is education. So when you see the master on Tuesday, you will see updates related to housing and the addition of a new domain of education. Next slide. So housing was always complicated. For housing, the first version that we had what about housing do I need help with? And we had finding shelter, finding and keeping permanent housing, programs that maintain and improve housing quality and safety, situational housing, which is supportive housing for specific populations, and housing navigation. Really, the complexity happened when we tried to sort all of the programs we had across situational housing, finding and keeping permanent housing, and finding shelter. It just didn't work, especially when we were thinking about the complexity of how people access housing programs through HUD housing programs like homeless management information system and homelessness programs, and the various ways that HUD supports entities with rent stabilized, whether it be through a voucher or public housing or any of those different methods, right? We couldn't fit everything well, and it didn't actually seem to be granular enough to navigate effectively.
Sarah,
Yeah?
what about rental assistance? Was that ever
Oh,
in the
yeah.
program super type? Is that somewhere in here that I don't see explicit?
You will see it called out exactly in a specific subtype in the next slide, dear Lucy. And then if
Great
we have
minds.
time,
Okay.
I know. And if we have time, I will take you to the classification master that really focuses on financial supports for housing, and rental assistance is within that.
Thank you.
Yes, absolutely. Because again, Lucy, what you just said, I can't find that here, is why we did the whole thing. Where does rental assistance go? This primary way that we support people. Okay, next slide. All right, so what we're working on, again, lots of meetings, draft version presented this morning at this meeting. We all feel comfortable. Again, it's like all airing of all the laundry, right? So this is what we're working on now. Some of our subject matter experts have already come late breaking and offered the idea that actually subsidized housing is not broad enough, because subsidized housing invokes all of those very specific HUD programs and not all financial support programs or HUD programs. So we'll figure that out as we go forward. But these are the new groupings that we're working on roughly. So finding immediate shelter, and you'll see how that plays out. Temporary housing programs and homelessness prevention programs. And this is like not long-term housing, here for a brief moment of time and trying to prevent homelessness. And this is a huge area that was not called out in our prior classification structure. We have two different types of supportive permanent housing programs. One is supportive housing programs that offer specific functional supports, and you'll see that play out. This is a new section. It was thought really, really critical from our folks that actually help people navigate to services. And that was an area that didn't have a match for some gravity programs before. Then we have our subsidized housing programs. Again, the name might change because it's really about any program that offers financial support, including public housing, Section 8 housing choice vouchers, community land trust programs, rent assistance programs, et cetera. Then we have programs that, then we have our programs that maintain and improve housing quality and safety. Oh, I'm missing a type here. Again, you can tell I made these, you can tell Sarah's really busy. There is a missing program type here, but it's definitely in the master, just so you know. It's just missing on this lucid chart thing I made about programs to assist with housing stability. And you'll see that again on the master, not in the slide. Next slide. I want to see if I can take you to the master. It's 525, probably not. Oh. But again, all of these different concepts will be on the master. The master is complex enough that we create things in the sandbox. I create a version of the master that reflects the changes of how things are sorted. And then Molly and Sarah are going to update the master. So it's like a multi-step process because of it's not just one concept, it's concepts and how they relate to each other. So I have to do my work first, and then they will be able to do theirs. So this is a new area of work that we mentioned we were working on before. So it's we tried to lean into education that's specifically focused on attainment of specific educational statuses. Originally, education and enrichment were all in the same area. So if I wanted to learn how to do pottery, it was in the same place as how to complete high school, right? So in order to specifically focus on those individuals who are really trying to achieve basic fundamental educational statuses, we have a specific call out for that now. We have 3 different types: receiving education, paying for education, and successfully completing education. And we have the different groupers that are connected to this. This is, again, the first time you're seeing this on the master.
Sarah,
Yeah.
dare I suggest a different word here? Instead of receiving education, degrees, and so forth, how about achieving education? This is what people want to do. They want to achieve something. And using the verb receive sounds like they're just taking stuff in rather than it takes
No, I hear
effort
you.
to
No, I know.
achieve education. So
Yeah. And that's,
maybe think about that different verb.
I
Okay.
like that verb. And then I actually was thinking about that, something similar myself, dear Lucy, longtime friend. And then I realized that made successfully completing education kind of awkward. And I think that doesn't mean it means it should. I think we need to revisit both personally.
Okay.
So does that make sense? Because I don't think we've leaned into what is in program class, because we used to think it didn't matter, the super type grouper, and now we know it does. In the beginning of our work, it was like, whatever. So, but we need to fix both of those, I think, in my mind. And luckily, again, we have a really amazing group of subject matter experts to help us with this. I don't see, oh, Molly's on the call. Hi, Molly. And Nicole's on the call too. We have friends from 2-in-1 and friends from Unite Us on the call. So thank you. Nicole, I'm gonna call you and say, you've been so fun. It's nice. But just noting for our next meeting, that we have to lean into that one. Okay. I do not have time to go, but I want to state the late breaking idea regarding the payment was from our friend Molly. I saw that comment, I responded to it. So when you see the master on Tuesday, it will reflect the master as it is right now, which involves some of the awkwardness of the wording, but we're going to be figuring out. We meet again weekly with our subject matter experts. All right, it's 5:28. At least the high level stuff got. If we go back a couple slides, the most important, the addition of education and the new structure here is the most significant difference in the master when you see it on Tuesday. And I'm missing a subtype, my apologies. But the most significant thing that you'll see is dividing what used to be only 2 groupers up into 4, right? Because immediate shelter is unique. Temporary housing programs and homelessness prevention is unique. Finding housing that supports people in their functional needs is unique, and helping people pay for housing is also a unique thing. So it took hours to get there, but we broke it apart. I'm really grateful for all of our friends again who are helping us map this to other classifications. Homework. Whew. Next slide. Homework is to review all the materials on the Confluence. Again, I'm going to fix some of the slides because the slides will be the master-ish for coding for food. The draft classification will be posted on Tuesday. I have to do I have to do the sorting according to the structures, and then I have to create a new draft master, and then Sarah B and Hamali will version it to the true master. So track changes, change logs, and then we will see you in 2 weeks to come back and keep on talking. Thank you so much, friends. Any final thoughts before we call it? Grateful for all of you.
Sarah, this is really cutting edge stuff. It's bringing classification and standardization to a huge amount of social activity that's gone on for at least 100, maybe more years, but hasn't really had the platform or maybe the need to organize itself in ways that can be written down like this, ultimately coded.
Thank you, Lucy. But I also want to note the cool thing about this, and yes, thank you so much. It's like another example where Gravity, I think, is creating space to integrate the expertise of what's been happening in the social care ecosystem for a very long time. Because I don't know if you've ever seen some of the sophisticated taxonomies out there that, community-based organizations have been using to understand themselves for some time. But the cool thing is everybody's around the table. We have everybody at the same table trying to work on shared language, which is what we do here. So grateful for our SMEs across 2-in-1, Unite Us, Find Help, and Epic, and 2-in-1 San Diego. Brilliant people. Go team. And I'll see you next week from DC after the high tech meeting. Bye, friends.
Bye.
Thank you.